Hi, Dr. Kenneth Hughes in Los Angeles. Today we'll be doing part two, which is explanation of tummy tuck and perhaps some things to consider before undertaking the tummy tuck and the selection of your surgeon. A tummy tuck is, in its simplest form, it is a way to take care of loose abdominal skin and the existing fat underneath, as well as fixing any abdominal wall laxity. Okay, this can be rectus diastasis, this can be global laxity, it can be any type of laxity. In addition, you are transposing the belly button. In other words, the belly button is being shifted on the abdominal flap. It doesn't really change the underlying nature of the belly button where it's retained on the abdominal wall, and that's due to the blood supply. So that part remains intact. So who are the good candidates for this procedure? Patients who have had pregnancy, one pregnancy, two pregnancies. People often ask, can this be done after C-section or multiple C-sections? And the answer is yes. Can the scar be incorporated into the tummy tuck scar so there's only one scar? The answer is yes. The patients who may also be good candidates would be people who have lost a lot of weight. Those patients have skin laxity, maybe not as much of an abdominal wall laxity issue as someone who's been pregnant and the uterus has resulted in that kind of laxity. But those people have loose skin, and the loose skin can be improved and the appearance can be improved by performing a tummy tuck on those patients. Some patients, just for either due to previous surgery or maybe a bad roll of the dice genetically or environmentally, they just develop loose skin, and it's better to kind of do those tummy tucks for those people. In addition, sometimes liposuction's been performed on a person and there's really no other remedy other than tummy tuck. Now, I will say that I do a lot of body tight of the abdomen. A lot of times tummy tuck can be avoided, especially in liposuction revision patients. It's just that the tummy tuck is conceptually and technically easier to execute, okay, than some of these body tight and liposuction revisions. So even though I do a lot of them, probably 95% of people would say, just do a tummy tuck in those situations. That's fine, but patients frequently want to avoid the scar, so I'm all for avoiding the scar. Now, on a tummy tuck, you should always make the scar relatively low. Now, there is a limit to this, okay? You don't want it at the leg crease, okay? It needs to be above the leg crease or the growing crease, and that's so that you aren't walking and having problems with that scar, okay? So it's generally about an inch above that crease. Now, I try to make the scar flat. Now, that's dictated somewhat by anatomy. If the person's pubic area is such that it's very low and the growing crease is very high, there will be a slight contour to that, but most people, it's fairly linear, that relationship, and so the scar is relatively flat. So you need to make the scar low, flat, and then that can be preserved as well as possible within kind of undergarments or swimsuits or something that the patient wants to wear, okay? Now, a lot of people will mark the person before the surgery and just excise that whatever they're going to excise and kind of no thinking involved. That's fine as well, but I found that pre-programmed markings and estimates do not produce the best result. It's been my experience that typically there are factors that you cannot evaluate adequately preoperatively, like the amount of distensibility of the flap once it's been dissected. How much extra loose skin do you actually have? How easily manipulated is the umbilical stalk? Is there some tether from scar that needs to be released as well? Will certain parts of the flap stretch as much as other parts of the flap? Will that alter the scar, okay? Because if you draw that pre-programmed kind of excision pattern, yes, it's symmetric, but rarely is a person's underlying anatomy going to yield symmetry in every aspect. So it's very critical to kind of, if you're going to mark, just perform the surgery, and then after you're finished with that, don't be held to those marks. Try to make the result as nice as possible. So now, when you go into the surgery, what you're kind of expecting is, these are usually performed under general anesthesia, which means you're asleep, which is good for the patient because the plication in particular can be difficult to tolerate, okay? Although you're only supposed to be taking bites of the fascia, that fascia kind of overlies the muscle and the contractions, and all of that can be very painful. So you're doing it under general anesthesia. You make an incision lower than the existing C-section scar, within the C-section scar, or an inch above the growing crease. I typically make the incision also about 7 centimeters above the vulvar commissure, and I do that on stretch, and so that gives me an idea of how long that component will be. You don't end up wanting a vulva that's, you know, pulled up like suspenders, okay? That's not an attractive look either. So, and you can alter that at the end as well, I'm not saying that, but I typically start that incision at that point. Make the incision as short as I can to start. You can always lengthen it if you need to. Then I perform the dissection. You're kind of on top of the fascia. If you happen to isolate hernias or something of that nature, which is actually pretty common, then you need to repair those hernias at the same time. Also, if a person has a pre-existing hernia that you know ahead of time, the tummy tuck is actually a nice kind of repair, because you can repair the tummy tuck primarily a lot of times without mesh, and then you can kind of support that hernia repair with the fascial laxity, okay? So if you have a diastasis or something of that nature, and you have a midline hernia or an umbilical hernia, even a ventral hernia, you can use that laxity, and that can create a kind of like a double layer repair that's very, very nice. So if you have the hernia, be cognizant of that, because that can prevent a lot of recurrence. The number one problem with hernia repair is recurrence. So consider that very heavily before you even consider doing, you know, a hernia repair in some other fashion. You may not have even considered a tummy tuck, but if you have loose skin as well and you have a lot of laxity, that's a very good way to address those issues from a medical standpoint and a cosmetic standpoint. So as you're going up, you're preserving the umbilical stalk, looking for hernias, looking for the fascial separation, you know, fascial laxity, etc. And sometimes this is global. Sometimes there's a rectus diastasis or a gap, and what you do then is you can put in suture material to kind of bring that gap back together. You should never really over tighten that, okay? Make it non-anatomic, especially in people who are bodybuilders and things of that nature. First of all, it would look crazy if they lost a lot of body fat, because you'd have overlapping muscles. Secondly, that's very uncomfortable from a physical standpoint. So what you're trying to achieve is anatomic normality, okay? Not something that's just cinched down as much as possible like a corset. I hear that sometimes, and you know, I don't exactly know how to respond to that. Yes, it's nice to have a small waist, but it's even better to have a functional anatomy, okay? So small waist, functional anatomy. Sometimes I put some sutures in the obliques as well if they're particularly loose. Most of the time, though, it's a rectus diastasis issue. You plicate that. It's also important to dissect all the way up to the xiphoid, okay? A lot of surgeons will leave that area, won't dissect up because it's quicker, etc.